It's a real pleasure to get to speak to this group today. I'm going to go over my background in a little more detail as I go through the talk because it's germane to why I'm here talking today and some of the observations I'm making. So we'll get back to that in a minute. But thank you for the kind introduction. So the EHR is really becoming the air we breathe in clinical medicine. It's indistinguishable from normal operations and from the workflows that we engage in. Yet we remain very challenged in the utility of the EHR and how well it supports our clinical activities. We really can't continue to tolerate the mediocre implementations that we've had to date because of the impact that it has on the clinical and the business portions of our work. How we as informaticians, as informaticists, participate in the evolution of the EHR will define us and the care that we provide for decades going forward. This is a really important transitional time for us. I had to put this in. This is an extended slide on conflict of interest because I am a walking conflict. I work for a consulting company. Everything we talk about today I do for a living, so I can't pretend there's no conflicts. There's conflicts all over the place. I'll stick to either facts or neutral opinions. I won't be very promotional, and I will try to keep the commercial aspect to a complete minimum. Also, I want to, in terms of disclosure, there may be some, what at least in my opinion, will be mild overstatements to make some points. I'm looking for discussion and pushback at the end of this. I'm not taking moderate positions in this talk, so feel free to jump in at the end. Aspen is a 100-plus person consulting firm. We focus on strategy and planning, and my role there is really in the informatics portion of the business, which gives me the perspective, and which is why I'm going over this slide in a little detail and the next one. I want to give you a sense of where the opinions and perspective that I'm presenting today come from, and give you some background on the exposure that I've gotten. It's very different than what I've done in the past. We'll talk about my background in a minute. But we are a virtual company. We really don't have a building anywhere that we go to, so we're all over the country, and as a result, we get to see lots and lots and lots of healthcare organizations. I mean, this is just tip of the iceberg. Everything from tiny little rural hospitals, some critical access hospitals, all the way up to some of the leading institutions in the nation. So it's, as someone who joined the consulting profession just 3 years ago and was really a hospital-based and community-based physician, this has been a real eye-opener for me and has caused me to come to a number of realizations that I wouldn't have otherwise. So some other disclosures. The topic of this talk is the science of implementation and operation. That's the first episode of hyperbole and overstatement. There is no science, in my opinion. Not to say there's not a science of usability and user experience, but I think we've been way deficient in the science of what really makes EHRs work and be useful in clinical practice. That there is no science, and that's the problem. But informaticists, I believe, are the scientists who will crack this nut. And it's the academic informaticists who I think need to take a new role and a new perspective well beyond what we're already doing. So the goals for this session are that we talk a little bit about this transition from being a kind of a regular physician to being a consultant just for fun. And also give you a perspective on what I'm seeing over the last 3 years as success factors in the use of EHR. What works and what doesn't, because there are some places that are doing this spectacularly well. To identify some emerging trends and what I think are potential future roles or role definition for clinical informaticists, and to propose sort of a new portion of how informatics research might be conducted, a little bit of an extension. So, I was, most of my career, I did resident education, family medicine residence in community hospitals, and I was a residency director for 7 years. I also did 7 years of performance improvement. I led a team at Virtua, about a 1,000-bed, 2,000 physician IDN over in South Jersey. And I'm a Six Sigma Master Black Belt, for what it's worth. That means I did 70 or oversaw 70 Six Sigma projects. I taught with GE out in Waukesha for their Healthcare Master Black Belt course. Actually really breathed deeply and was very impressed by what performance improvement can do for organizations. It's not a soft science, and it can be pretty powerful. And I've been lucky to have a lot of administrative experience in my various roles in healthcare. So I come at this with an interesting, for me anyway, perspective on health systems, on clinicians, and on the resources we use. I did a lot of internal consulting in the organization I was at, so I felt well prepared for this role. Doing that Six Sigma for 7 years, you had to find the projects, scope the projects, work with people, internal customers, and really develop some consulting skills. So I felt pretty well prepared to transition into consulting. And I think I'm pretty realistic about how people perceive consultants, because I saw lots of consultants when I was on the other side of the fence, so nothing you can say will hurt my feelings. The kind of work that I've gotten to do, a lot of implementation support, a lot of planning around implementation, something that I wasn't as aware of in my previous roles. The amount of rigor and time that can be spent in system selection, in comparing the competing systems that are available for organizations that are replacing their systems or putting in new systems, total cost of operations, some really rigorous methodologies around that. Program reviews for folks who are in the middle of putting in big installations of these very expensive EMRs. We will come in and do kind of a cross-check on them and how they're doing, sort of an independent audit and third party at their request to make sure they're on track. That's been a source of tremendous insight about what's working and what's not right in the heat of the moment as they're implementing their EMRs. I actually am being called on a great deal now to do some physician-focused activity, mentoring new CMIOs who are in the development stages, and also to help organizations bring their physicians into more of a partnership role with the organization around the oversight and evolution of their electronic medical records. If you want physicians to be engaged, you can't just serve food at dinner, at dinner time and have them come to meetings. That physicians in the business side of healthcare with clinical integration are being given and pulled into very authentic leadership and partnership roles with healthcare. Yet in many organizations, the IT department still seems to be running things, and that's starting to go away, and organizations are realizing that they need to change the way they do business with clinicians to involve the clinicians directly in the oversight of the EHR and make it really function. So that's a lot of the work that I've been able to do, and some really, for me, interesting lessons learned. Consulting has remarkable parallels for me as a clinician with patient care. I've probably been to 30 healthcare organizations in the last couple of years, and when you go in as a consultant, just for fun and laughs, it's really very much like interviewing a patient. And you take a history, you find out what are the challenges that you're facing, what's not working the way you'd like it to. You do an exam by looking at objective evidence, looking at their workflows, looking at their performance. You are in a relationship of mutual voluntariness. They don't have to listen to you, and you don't have to engage with them, very much like patient care, which means you really both have to perform very effectively in the relationship. And then you make recommendations, and sometimes they follow them, and sometimes they don't. And when they don't, just like in patient care, you follow the natural course of the disease. So really, the parallels and being a physician, I felt equipped me very well to do this work. A lot less salesy than I thought. It's much more about truly aligning with clients and being helpful. So a lot of the things I was worried about being a consultant really didn't come true. It's really been kind of a delightful kind of work to do and really helping organizations to move forward. It does give me the chance, I think, to offer a unique perspective on the industry and what's going on out there. And I can say that there are lessons learned that I never heard when I was on the other end being a CMIO. There are observations you can make by this aggregate experience that I think is hard to make on an individual experience. So, enough of the intro. Now, where are we? From my perspective, from the perspective of someone who gets to see a lot of these, and I want to be really clear, everything I'm saying today is anecdotal, or almost everything. And one of my arguments is we need more examination of what I'm seeing that's not anecdotal, that's systematic and analytic. And I think that's going to be an important point. But what I'm seeing is that the penetration of EMRs, based on data from HIMSS and other places, is definitely growing quickly, but we still have a long way to go. Surprisingly low adoption in many settings, and hospitals are not as far ahead as you would think they would be with all of the meaningful use and other incentives that are out there and all of the pressing requirements for data. Functionality, as you break it out by the components of an EMR, it looks to me, and I think most would agree, that CPOE is fairly good. It's working well, kind of settled law on how to do CPOE well. Not alerts and decision support, but the basics of electronic ordering. It's pretty clear what works, and there's some great references out there about how to implement CPOE effectively. Physician documentation is startlingly weak. It is really bad. It is undisciplined. It's the Wild West. Many organizations are struggling with notes that are meaningless and overloaded with junk, and these are not technical problems. I want to tell you that. It is not a technical problem. These are governance problems and problems of professionalism and self-discipline. So that's been a big learning for me. Decision support is getting there, but there's a long way to go before we get decision support right. Connectivity is still mostly a twinkle in the eye. It's much better when it's within vendor settings than between vendors. Some vendors are very adept at connecting anybody who's on the same platform within a single instance. Not bad beyond the single instance, but horrible beyond their platform. And then most vendors are actually just horrible anywhere outside of their instance. The impact on all of the things we care about is very substantial. So we have a long way to go in where our EMR is. But here's what I think about why we are where we are. This is the part that I think is a little different from what I usually hear and what I see on listservs. The results we get are a combination of two things, and they both have exactly the same words in them. It's just how those words are arranged. What we hear a lot of is how the vendor built what we use. We hear that all the time. It doesn't do this, it doesn't do that, it can't do this, they didn't do this, the vendor stinks, they didn't use user interaction assessment science. And I agree, that's true. But what I think is more important is how we use what the vendors build. And that's where I see the biggest gap when I go around and look at implementations of electronic health records and where organizations are struggling. And the main point I'm going to make today is we should be spending a lot more time on this than we are. And we need to get much more disciplined as healthcare organizations and worry about this later, because this is outside of our circle of influence. We really can't change this. All we're doing when we go on this route is gnashing our teeth. So where are we in the evolution of the EMR? We're right in the middle of it. So it feels really weird, like you can't tell what's it going to be like 10 years from now. Are we almost there, or are we still very far away from where we want to be? So let me walk you through this one, and let's have a little fun. So this is actually a picture from Woodbury, right across the river just above Glassboro. This is from 1905, and this is from their Historical Society. I hope they don't come and get me, because I really didn't get a copyright release on this. This is a doctor in 1905. Dr. George Redding, I think is his name. And he's riding around in a 1905 car, doing his rounds, his home visits. Isn't that cool? Right? You know who this guy is? This guy is not, he's the driver. He's not a driver because this guy's an elitist. He's not the driver because he gets lost a lot. He's a driver because every time this thing breaks down, he goes back to the house and gets the horse and buggy and helps him finish his rounds. Okay? From an EMR perspective, I think we're past that stage. This is a Model T assembly line. At this point, we've got standards. We know everything needs 4 wheels. We know that it needs to have a seat. We know, oh, we should probably put covers on the top. That works well. And they're all the same. And they're actually, you can produce a lot. And a lot more people use these than use this. And you could usually get where you were going in this. Wasn't luxurious. Wasn't perfect, but didn't usually break down, and this guy is now out of a job, because usually you can get where you want to go. But notice, oops, somebody's got to undo that there. Notice there's still a hand crank on the front of that thing. It is not convenient. You can imagine lots of ways that this could be better, but it worked. This is only 10 or 12 years later, maybe 14. Just a few years after the Model T, maybe a little more. But these cars now have plush seats. Some of them might even have radios and stuff in them. They start by themselves. They have electronic ignition and a starter motor, and they're very reliable. They still got flat tires a lot and things like that, but they were pretty darn good. And this is a car, I'm a little bit provincial, this is the interior of a Subaru. It's got things that these guys couldn't even imagine, right? Functionality, you don't worry about if these things go 250, 300,000 miles. All you have to do is change the oil. They can tell you where to go. Pretty soon we're going to have things, the cars are braking without us even thinking about it because we're not able to react quick enough. So where are we from an EMR perspective in this? And I think we're about here. And I don't think I'm being harsh. We know we need CPOE. We know we need physician documentation. We know we need information exchange. We've kind of got the fundamentals down. This, I believe, is where we were when we had mostly homegrown systems or where we were pushing financial systems to begin to do some clinical work for us. It was really idiosyncratic. Your IT team was absolutely essential. You had downtimes all the time. It just wasn't something you could count on. And you had, when I started our conversion at Virtua to CPOE, Siemens had a 15 to 20% adoption rate in the hospitals that had implemented CPOE. They didn't have basics like save your own favorites, things that made work, putting hold parameters in a beta blocker order easy. So the adoption was horrible. We're there now, but I don't think we're even here yet. And I think what we're asking for is this, and where we are is here. And I can tell you the sad story is it's not going to happen overnight, so let it go. It's not what you should be spending your time thinking about. A little hyperbole, not too much. So, this is what I think happens in organizations that are ineffective. They weigh very heavily and spend a lot, and I mean, this is not speculation, I see this every day. This is what they talk about. The vendor can't do this, the vendor doesn't do this. Look at our listservs for AMDIS, filled with this kind of talk. And it's gnashing of teeth. It's railing at the injustices of the universe because this is not going to change quickly. This you can change in a moment by just paying attention and saying what really works. But remember, we don't have science on this yet. We have speculation and anecdote, which I am going to freely supply today. But we do not have science on this. This is what we need to be focused on, in my opinion, as a discipline of clinical informatics. So when you hear conversations that start with, well, the vendor really can't, that's not worth hearing, I don't think. Unless maybe in an academic medical center that's doing a lot of usability research, but not in general. So here's a question. How well does the EMR work? Picture of a Corvette underneath a Jeep Cherokee, and the Corvette caused the accident. Corvette's a nice car. Works great. Why did this person get this result and this person get this result? And my message is one of accountability and self-empowerment. If a tool can work well anywhere, well, it can work well anywhere. If you're complaining about how your EMR is functioning and you don't know who the most proficient users in the country are of that platform or that functionality, and you haven't compared your installation and your utilization to theirs, and you're not matching theirs, then shame on you. That's the clinical informatics role going forward, where you have a lot of job security, because we're not doing that. But stop asking what the vendor can't do and start making sure we maximize what we can do. So a little story or something to reflect on that I think makes this point again. Let me see, I'm doing time, not bad. This is what I'm calling the outcomes trinity. There's a couple of stories, both of which you're going to hear from me today, about how EMRs work. This is the historical study, which started here in part, in some articles by Dr. Capel. This is about elevated mortality in Pittsburgh Children's when they put the EMR into their ICU, their pediatric ICU. And they had an increase in mortality. This is a story from Seattle Children's, where they did the same thing, and they had a decrease, which was non-statistical, so it's called no association, but they actually had a tendency towards a reduction in mortality in their ICU. And then this is Chris Longhurst's article from Lucille Packard, where they had a decrease in hospital-wide mortality. So this is not all apples to apples. This is hospital-wide. These are both ICU. These guys, no one talks about this a lot. They recovered a few months later. They did fine after a while. But the question is, why, using similar tools, do we have these disparate outcomes? It's not the tools. It's how they're implemented. How are we doing on quality and patient safety? I'm not even going to waste my time talking about that, right? Okay? I don't think I have to convince anybody that we've got a long way to go. How about financial performance? What's in front of us? What's the compelling argument from a business perspective that we have to do this stuff well? This is a great monograph. It's actually got nothing to do with IT, except that IT in healthcare is now everything we do. Look at some of the recent challenging go-lives from a financial perspective of one of the major vendors, right? Whose software is fine. It was the implementation that was the problem. This is a must-read monograph. It's from the advisory board. If you guys have access to this, I would go get it. It's called Running on Medicare Margins. What they do here is they create a 300-bed model hospital, and they look at reimbursement rates and other the financial components of income coming over the next 5 to 10 years. Really, I think they go out through 2021. And they show where they project savings have to come from. There's a truism out there that this is reinforcing that we have to take 20% out of our cost structure in the average health system. Not 2, not 3, 20% out of our cost structure to recalibrate for the reduced utilization and the reduced rates that are coming in the near future. This may not apply so much to a specialized children's hospital. You may be in better or worse shape, it depends. But for the average healthcare system, this is what they're looking at. And this shows how those savings are apportioned. All of these require operational excellence, something healthcare organizations are not known for. The real message of this slide is, after that 20% comes out, say 5, 8 years from now, if you're one of those hospitals that's still out there and you haven't closed yet or been merged, the real differentiator, and no one's talking about this, is the next 2 to 3%. Because if you didn't get the 20%, you're out of business already. You're history. The real challenge is that 2 to 3%. And where does that come from? Operational excellence, flawless execution, industrial level performance for all our processes and all of our key competencies. And I don't think healthcare is preparing for that. We're still trying to reduce department size, and we're trying to preserve, the volume to value transition and stay with volume as long as we can. But those organizations that are looking at performance in an objective way are going to be at a big advantage. So, as an organization, and now I will refer back to Aspen, but not to try to promote anything, we look at these as areas that are core to being successful as a user of healthcare IT. These two are kind of, I think they're infrastructural, and I'm not going to spend time today on those, although they should work well. But I believe, and this is based on a lot of the work I do and the firsthand experience I have, that it's about governance, change leadership, and performance improvement. When I say operational excellence, this is what I mean. You have the right people involved in decision making, the right people engaged in the management and evolution of your healthcare IT systems, that you have the ability to implement change quickly and effectively, and that you know as well as anyone what makes change stick, because you can't afford failed change initiatives anymore. That's where you lose that 2%. You put an initiative out there, it's a great idea, but it doesn't stick because you don't know how to change. Not the organization doesn't. The people driving it don't know what it takes to support effective change. You fail, and you have to recalibrate. And performance improvement, because if we don't make our processes better, we won't get there. So here's the second story that everybody worries about. Everybody worries. When you say I'm putting an EMR in, they say, I hope it's not a CedarsSinai outcome. Right? CedarsSinai, this happened a long time ago, and let me tell you, this is not speculation. This is firsthand observation. This is from someone who was there. CedarsSinai was putting an EMR in. It was a homegrown version, but it was technically sufficient. But it was top-down. It had some significant problems with workflow because they didn't engage the end users in the design of the system. They did not gain the support of the medical staff, and they just mandated its use. It lasted, I think, 2 weeks, and it was voted by the medical staff to shut down, and they pulled it out, and it became one of the famous implementation catastrophes of healthcare IT. This was not a technical failure. What did they do? They went back, they demonstrated successful use of the resources in a controlled setting, they gained adoption, and they implemented change leadership principles like, here's why this is important, here's what it means to you, here's how we took into account the impact that it's going to have on you, and here's how we've mitigated that impact. And they were successful in their go-live. And they've been fine ever since. We could afford this back then. They could afford to do this. Very affluent system. Famous in a way they didn't prefer to be, but they made it. We're not going to have second chances in the future is my belief. So let me set off those three areas of proficiency and show you the stories of successful and unsuccessful organizations and contrast them for a few moments. So the first area is in clinical IT governance. And here we have an organization that is struggling. They're a multi-hospital system. They have a well-established EHR. They're just trying to get people to use it effectively. They have multiple medical staffs in these various hospitals. They have numerous IT committees. They have vague responsibilities. They're not specific on who they represent or what their responsibilities are. Clinical decisions are driven by IT, not by desire, but by default. The way I put it is they're hearing the input of the physicians as if it were the Mormon Tabernacle Choir and everybody's singing a different song. They don't even know what to focus on to improve the user experience because they have no coordinated forum for consensus development by their key users. The outcomes is they have an inability to gain consensus on any of the key functions of the EHR, and they're having suboptimized EHR and a very discouraged user community. This is an organization that has multi-hospital. It's multi-hospital. They have an established EMR, very similar in characteristics. They have 2 medical staffs, so they have similar kind of fragmentation. But they have a 14-member advisory group made up of physicians exclusively appointed by the presidents of the medical staffs, both of them in collaboration, chaired by a member who's appointed by the presidents, not by administration. The hired physicians, the employed physicians, serve in a support role to this committee to make sure that they're addressing issues and have the resources they need. And they all enhancement requests that go from the clinicians, including nursing, goes through this and a combined committee with nursing. So the clinicians, when they say, you know, we can only do 10 enhancements this month and every month, the clinicians decide which 10 get done, not IT. The physicians are engaged. The last time I checked with this organization, about 2 weeks ago, at one of the combined meetings between this group and the Nursing and Ancillary Committee that serves a mirror image for them, they had 70 attendees. The meeting lasted 1 hour, was well governed and well controlled, executed flawlessly, and every month they put through their enhancement requests through this committee. Very different way of operating. So, what do clinicians want to be engaged in this kind of process, to participate? They want something that's efficient, inclusive, meaningful, discretionary. If it doesn't matter to them, they shouldn't have to spend a lot of time. Genuine, transparent, asynchronous. Ideally, not requiring in-person presence. Conclusive, meaning when they decide, the decision sticks, and persistent, that means that over time you can refer back to this and those decisions still hold sway. I'm not going to spend a lot of time on this slide. It'll be in the handout that you have available. But think this is a different kind of thinking about how you get your physicians and nurses involved. You can be very explicit about what decisions a group like that can make and at what level those decisions are made, so that you've outlined for the organization an approach that everyone now is aware of and can agree to about how the clinicians will be involved, what they can decide, all the way down from who can correct a typo on an order set. That's an analyst. But who can change the content of a medication order in an order set? Not the analyst. So these things are explicitly defined. Everyone knows there's no ambiguity. So that's a very quick blow through governance, but I cannot tell you how important that is to getting the engagement you need. Change management. One organization here is a large academic medical center, a lot of control, all in one place, not spread out all over the place, but there was a lack of alignment of leadership behind the initiative, a large go-live. No organized change management framework. They just thought communication was change management and that was enough. No dedicated staff to help shepherd the change through the system. And limited evidence of assessment or mitigation of impact on stakeholders. They found a lot of this out after go live, and the users were very discouraged. The outcomes were they had extremely poor clinician engagement and substantial operational failures at go live. A similar sized organization, also an academic medical center, for community hospitals, so complex environment. Their leadership team spent several weeks with a consultant developing a compelling case. And I'll tell you about that more in a minute, for why this change was happening. The leadership team was completely unified behind the change. They communicated it effectively, and they even went so far as to go out and make sure every employee had a facilitated 1-hour session that helped them understand how that change that was coming, this new EMR, was going to affect their workplace and the care they were able to provide. Major effort at just getting engagement and adoption, but it was breathtaking how well it worked. This is one change management framework, and I only show, this is the one we use. It's not ours. We have nothing to do with it. It just shows that change management is not soft or unstructured. And if you understand what it takes to be effective in change management, you'll realize that everyone I've been able to find, and I've looked through a ton of these, they're all the same. Some of them try to be different to sell their books, but by the time you get to the middle third of the book, they're all the same. Leadership has to be behind it. The impact on the users has to be understood, communicated. There has to be fair representation of their needs, and then there has to be something to bake in the change and make sure it's going to last, because you're asking people to invest. Change management means I'm asking you to invest in my idea, and I have to sell you. I use a slide in other talks. It's like the Shark Tank. They want to invest, but they have to be sold. They have to believe in you, and many organizations miss that point. This is Henry Ford Health System, and this is on the internet. This is nothing proprietary, but they did this amazing change management approach that that is a best practice. If an organization is doing a major implementation and they are doing less than what Henry Ford did, then they are intentionally handicapping themselves. Okay, change management. Everybody still with me? It's like taking a little sip from a fire hose. Sorry about the pace. Finally, performance improvement. The first case is an example of community hospital. It's an integrated network. They have an EMR in place. They have no organized performance improvement framework. They have a little bit of lean going on in the organization, but it's at the mid-level. There's no real leadership support for it, and it's kind of stalled. They've identified a lot of errors, delay, and other examples of waste in their system, particularly when they're doing the EMR implementation and upgrades. Every time you touch an EMR, you find processes that are broken. What's the organization do with that? In this case, the organization was stymied. They don't have a good systematic approach for how to address this. They attempt to fix problems and achieve temporary success, but usually they backslide and fall into prior existing patterns. The challenge here, they're challenged to meet quality and financial metrics. They're not satisfying patients, and they're basically suboptimally performing. This is a community-based integrated delivery network. They have an EMR in place. The leadership team chartered a multi-year deployment of a comprehensive performance improvement toolkit. So proven, established tools, standard methodology, led by leadership. They hired a senior-level, very experienced PI expert from outside of healthcare who knew how to use these tools and how to organize the department. They established monthly, all leadership on-hand meetings to review each of the individual projects. And leadership was visibly behind this. And that's important because these efforts are very transparent. You actually show how the organization truly is performing, and sometimes the answer is badly. And people need protection so that they can be candid and open in sharing how they're doing. And the outcome was they have a $125 million target that they have to achieve to get part of this 20% reduction that other healthcare organizations are not paying a lot of attention to, and they've already got $25 million in year 2. These are hard dollars. These are not projected. They're not even productivity, which should count to some way. This is hard dollars that are out the door or in the door in terms of revenue, but usually it's reductions. This is what their toolkit looks like, and this is University Hospitals in Cleveland. This was an open presentation, so I can share this information with you. And they don't just do Six Sigma, or they don't just do Lean. When someone says that to me, well, we like Six Sigma. My answer is that's like going to a mechanic who says, I kind of like wrenches, but I don't like screwdrivers. They bother me, you know? You should use the right tool for the right problem, and these things solve very different problems. So you can see and they said they do about 20% Six Sigma, about 60% lean, and about 20% qualitative problem solving. This is a best practice. If you don't have this kind of implementation in your organization to address your performance improvement needs, then you're automatically suboptimizing your opportunity to use your healthcare IT resources effectively. So they've been very successful, and they continue to move forward. They're easily going to hit that $125 million target, and that's going to make a total difference in how they compete in their community against other members of the community who are not as effectively deploying these resources. This is an example of other organizations or other approaches that contribute to this pool of knowledge around performance improvement. This is Jigna Mason. They are very heavily into lean and the Toyota production method, and they are a real best practice and a great place to look to if you're looking to establish good practice. This is a really simple approach. This is the Baldrige Award. The Baldrige approach is extraordinarily reinforcing of good behaviors and of explicit statement of performance and your intent to perform. I was a Baldrige examiner for 1 year, and this was transforming for me. So a great place to look for systematic performance assessment and improvement. And engineering fail-safe health systems, this is the direction we're going in. So then the question is, okay, so there's 3 great ways we could improve our performance, and I honestly believe these are essential, and I don't think they're just 3 examples. I think they are 3 core competencies that clinical informatics needs to be very interested in, because our success depends on effective execution in our organizations, and we cannot do it alone by complaining about how the vendor builds the EMR, or even by trying hard to make the EMR work in our organizations. It takes all of this to be successful. Now, healthcare is different. You know, when you bring these tools in and you say, well, you know, that's great that GE does this, but healthcare is different. I agree. And if you haven't read this book, it's an old book now. It's like 20, 25 years old. This is one of the best books I have ever read about why healthcare is the way it is. It's a brilliant book about the history and evolution of the American healthcare system. So we are different. This was by a GE senior vice president who I heard speak one time. He said, you know, one of the things about comparing industries, banking is about transactions, healthcare is about interactions, tremendously more complex relationships. But still, we got to move forward because this is the business that we're in. So what do we know? What we know is that very successful approaches to the effective use of information technology are available from other systems. We know what works. We also know that identical resources in healthcare yield widely varying results. I showed you 3 examples. Those were all real examples of 1 or 2 organizations, very similar, same challenge, totally different outcomes. That variation is not due to their healthcare IT platform. That effectiveness requires much more than a better EMR, and that we can be much more effective with the EMRs we already have than we are currently being. So what's needed? We need to characterize and confirm the organizational competencies that are needed to be successful. I mean, I'm just a guy telling you what I've seen. But this stuff needs to become science because it's a differentiator. And I think it's important that the discipline of clinical informatics recognize how dependent we are on the organizational use of these kinds of competencies. We may want to get to the point where it's almost an informed consent level of warning when an organization chooses to go forward with a good technical solution, but they don't have the organizational competencies to execute it effectively. We should have that level of evidence about what works and what doesn't. It's available. And we should acknowledge the current limitations of EMRs and work towards the establishment of best practice standards for effective use. So my kind of main point in the end is that clinical informatics, either by mastery or by linkages, we may not as informaticians be able to be Six Sigma experts or change management experts or governance experts, but we sure need to know who in our organization is, and we need to develop partnerships with them And we need to make sure that for the success of our initiatives, for the things that we're here to do, that those pieces are working well. And if they're not, we have a partnership and advocacy role in making sure the organization understands the risk it's incurring by not establishing proficiency in those areas. So we are people, process, and technology, but I think we're surrounded by the effectiveness of our performance improvement, change management, and governance competencies. And again, speaking to some of the expertise that resides in the Philadelphia healthcare systems, I think this is a great opportunity for ethnographic research. This is an area that's very familiar to informatics. Joan Ash, Ross Capel here, one of the godfathers of it. This is not double-blind controlled trials. This is going into the real environment, looking at real healthcare systems in operation, in real settings, with all the complexity of our daily work, and teasing out what are those characteristics that distinguish those successful organizations from organizations that were unsuccessful and that continue to struggle in the implementation. The science of clinical informatics requires this knowledge. To the extent that we focus on EHRs, we're going to fail. To the extent that we worry about what the vendor does, we're just wasting time. But I think to the extent that we look at how our discipline fits into the competencies of a greater organization and how effectively we can establish that fund of knowledge and share that knowledge with the folks who depend on us for advice and support, I think that will determine in the long term the success of clinical informatics as a discipline. That's it.